So welcome everyone. I'm Najla Nasri from Johns Hopkins, and I'll be moderating the Journal Club session today. We're fortunate to have Dr. Hautz presenting on explicit reasoning, confirmation bias, and illusory transactive memory. It'll be a great session, so thank you for joining us. His training is in anesthesiology, emergency medicine, ultrasound, and educational research. His research focuses on diagnostic decision-making under ill-defined conditions and collaborative decisions in particular. He's published more than 30 peer-reviewed papers and was chair of our second European Conference on Diagnostic Error that was held in August. So welcome, Dr. Hautz, and thank you for presenting today. David will say a few words and then we'll turn it over to you.
Yeah, I just wanted to say thank you, Will, for coming today. It's a great pleasure to have you here. For those who didn't have the privilege of attending the European Diagnostic Error in Medicine meeting that Wolf ran with Laura Swan, it was really a superb event, extremely well put together, and we really appreciate your being here today. So without further ado, Wolf, take it away.
Well, thank you very much for your kind introductions. Thank you for having me. And as you see, we're a little technologically behind, so Skype is the most advanced it gets for me typically. So please excuse my technical failures and shortcoming in advance. I will try to present a paper that is actually not that new. It's published in 2009, but it's one of the better papers I've come across in recent years, and I think it's very related to things a lot of us and a lot of you have been discussing and investigating, at least from what I hear and what I read. So this report, I assume, is fairly familiar to everybody. It's the Improving Diagnosis in Healthcare 2015 report from the National Academy of Medicine. And very early on, this report says that diagnosis is a collaborative effort. And the stereotype of a single physician contemplating the patient and the diagnostic findings is not always true. And that the diagnostic involves intra and interprofessional teamwork. And as I said very early on page 7 of that report, the very first recommendation of this report is to facilitate more effective teamwork in the diagnostic process among healthcare professionals, patients, and their families. And I would argue that we really don't have a lot of evidence to guide us how we should do that and what, in fact, effective teamwork in the diagnostic process even is. And we might have time to discuss what you perceive as teamwork and what you perceive as effective teamwork. But I hope the study I picked for today sheds some light on why I'm not so sure that we really do know what we're talking about yet. Very briefly, as one of my own studies to investigate the relevance of teamwork in diagnostic process, it's a computer-based study where we randomized senior medical students into an individual condition and a pair condition. And they saw on a computer screen 6 cases that all started with a clinical vignette and a very brief 10-second patient video. They had the liberty to collect all the diagnostic information they wanted, then ultimately choose a diagnosis once they were considerably confident enough, and then indicate their confidence. And they did that for 6 cases. We compared that to an expert group. And what we found was that that is hard cases, as you can see. So the individuals solved 3 out of 6 on average, and the pairs 4 out of 6. But that's a very large effect. In fact, the number needed to treat, or the number needed to diagnose in that case, is 6. So if you diagnose 6 computer-based cases in pairs as opposed to alone, you'll get 1 more right out of these 6. which is a pretty large effect, I would argue. And but still, this study tells us very little about what goes on in these diagnostic teams. And so what Franziska Chan from the Université de Neuchâtel here in Switzerland, what she and her group investigated is 3 hypotheses. And the first hypothesis is based on the observation that groups often fail to successful pool information. That is group research that comes from the field of social psychology, and especially on business teams. And also, I think we're all fairly familiar with that the observation that in diagnosis, in medical diagnosis, individuals often fail to collect all information that is important, or to attend to or consider all information that that turns out to be important for that diagnostic case. So based on these 2 observations, Franziska's first hypothesis was that groups that consider a greater number of information are more likely to find the correct diagnosis. And I think that's sort of a very straightforward hypothesis. The other 2 are based on the observation that individuals often demonstrate a lack of deliberate reasoning, and the whole idea of debiasing diagnosticians is basically to make them reason through the problem more deliberate and more aware, or more rational, more system 2 if you're into dual process theory. Also that in non-healthcare teams, causal conjunctions have been associated with better performance. Now, a causal conjunction, that's if then or because statements. But again, that is finding from business research and social psychology. So the second and third hypotheses was that groups that show more explicit reasoning, that use more of these causal conjunctions, these groups will be more likely to find the right diagnosis. And third, that groups that engage in a behavior that they call talking to the room are more likely to find the right diagnosis. And if you go to the limited literature on healthcare teams in diagnosis, then you'll find talking to the room being used synonymously to thinking out loud or thinking aloud, which is basically what it describes. So the design of this study, it's a study where they included 53 experienced physicians. It was all placed in a hospital in a simulation center. So they brought these simulation dummies to this very site where these people work. They formed groups of size 2 and 3. The teams were formed based on scheduling preferences. This is one of these simulation trainings that I think we all have in one form or the other in hospitals. And they took care that the groups never worked together in a team before. So were from different wards or different areas of the healthcare provider. And then they had these teams of 2 or 3 physicians go through one simulated scenario with a METI simulator for about 10 minutes. And they conducted what I would call a prospective observational mixed method simulation study. And I'll come to this mixed method aspect later in the analysis part. So this is what it looks like. It's not from the study, it's from one of our studies, but it's a very similar setting. There's an emergency room physician that brings in this patient to the immediate care the immediate care unit, and there is 2 or 3 IMCU docs that this emergency physician hands over this patient to, and there's also a Confederate nurse in the room. That is a pre-instructed nurse who is part of the study team with a little headset in his ears, so the study supervisors could tell him during the simulation what to do, what to say, and so forth. And he was basically behaving scripted. But that's not so important. What is more important is the case the emergency room doctor presented to these colleagues. He said this is a male patient that came into the emergency room tonight. Demonstrated gave some demographics, gave the admittance diagnosis left side pneumonia with respiratory insufficiency, which is why he goes to the IMCU, and he gave some unrelated patient history, and he stated that the emergency room initiated treatment of the pneumonia with penicillin. And at that point, the ER physician's telephone rang, and he had to leave colleagues and the patient. He left and said, while leaving, he said, all other information is to be found in the chart, and he explicitly gave the chart to one of the IMCU physicians. And he also said, while leaving, that he had unsuccessfully tried to put a central venous line in the subclavian vein on the left side. And he had just started the penicillin because it took him some time to find another line. And so for those of you who are not of a medical background, this central venous line, this involves a puncture of the left side of the thorax, which is where the patient has his pneumonia also. And then this patient sort of evolved into a state of distress, respiratory distress. The saturation, oxygen saturation decreased, the heart rate increased, the blood pressure dropped a little, and the respiratory rate increased also. And as you can see, the patient is what I think we would call in sepsis or in septic shock, maybe even. The question here, or the question that team faced, was what's the diagnosis of this case, and why is this patient deteriorating? The case was specifically designed to be ambiguous. The intended diagnosis was that the patient showed an anaphylactic reaction to the penicillin, and it was in fact listed among the 8 diagnoses in the chart. The 7th in the chart was a penicillin allergy. Also, as physical findings, he would have obstructive breath sounds and a rash. The differential diagnosis is a tension pneumothorax that is a consequence of this failed central venous line attempt. But the patient did not have any chest pain, which you would expect in a tension pneumothorax, and he had clearly audible bilateral ventilation, and you would expect a decreased ventilation sounds on the left side, or even none, if you really had a tension pneumothorax. And the Confederate nurse had several hints at hand that she could use to guide the team towards the correct diagnosis. If they were struggling, that was, she would point to the skin color and clearly ask, is the patient is turning red? Why is that? She would hand the chart if the physician who the chart was handed to in the beginning, if this physician had dropped it somewhere or put it somewhere, she would hand the chart to a physician again. She would mention the penicillin that is still running in the patient, and she would, if asked to auscultate, she would auscultate bilateral breath sounds, or he. And what they did then with the data, they video recorded all of these simulations. They transcribed all communication within the videos verbatim, and they scored with 2 independent coders each team's diagnosis as either correct or correct with the help from the Confederate nurse, or missed. And on 19 out of 20, these 2 coders agreed, and the last they solved by discussion. Then all utterances, which is sort of let's say, objects of meaning. So that could be a sentence typically, or maybe a half sentence, were coded, and they were coded as being employing causal conjunctions. These because or if then statements I mentioned before, as talking to the room, as thinking out loud, and again, radar agreement was fairly okay. And they would also code physician behavior, such as reading the chart, auscultating the patient, and so forth. Now, what did they find? 2 out of the 20 teams found the correct diagnosis very early on by opening the chart within less than a minute. So they dropped these teams from the analysis because there wasn't much behavior to observe, and there wasn't much data to attend to the hypothesis. With the remaining 18 teams, they classified them by either solving the case as correct, or with help from the confederate, or as missed. And the first diagnosis is the amount, or the first hypothesis referred to the amount of information considered. And you see that there's no statistical difference between these 3 groups. So the hypothesis that groups that consider a greater number of information are more likely to find the correct diagnosis is in fact not supported. The second hypothesis was that groups that show more explicit reasoning are more likely to find the right diagnosis. And indeed, this finding is supported by the data. The significance overall is statistically, or the difference is overall is statistically significant. And also the groups are in an order that you would expect based on this hypothesis. So those that get it right, they explicitly reason much more than those that get it right with help, and those again much more than those that miss the diagnosis. A third hypothesis is this talking to the room or thinking out loud behavior, and again, groups that do engage in such behavior are more likely to find the right diagnosis. This behavior was rare in total, so they did observe it in 3 out of the 4 groups that got it correct, and in 1 out of the 8 that found it with help. But in all of those 4 groups that where this behavior was observed, it was observed once or twice the maximum. So what they also did is they sort of summarized this through a set standardized scoring into a combined index, and again found a statistically significant difference in the direction you would expect. So this is sort of the quantitative part of the analysis, and here comes the mixed aspect of the method, which is the qualitative data they looked at. And I've termed it the interesting stuff because I think that is very interesting findings to investigate further. One thing they observed is that 6 out of 20 groups found the diagnosis ultimately in the chart, and all 4 that got it right are among these 6. But 18 out of all the 20 groups did consult the chart, and 12 of these 18 did not find or communicate the allergy information that was on the first page of the chart. Another interesting observation they made was that whoever received the chart from the emergency physician remained the chart handler. They did not observe a single instance where another physician on the team handled the chart. What they did observe was that maybe the second and third physician on the team sort of peeked over the shoulder of the chart handler, but they would direct questions to this chart handler if they had questions to the chart, and then the handler would look it up. And if you consider that the chart was handed by the ER physician to the team sort of at random, that is quite an interesting finding to follow up upon. I guess the question how we distribute teams among distribute roles among diagnostic teams. And what they also found, like they described that in group 12, that this chart holder at some point reopened the chart after a Confederate gave him a hint, this Confederate nurse. He then immediately stepped to the intravenous line and stopped the penicillin drip, acting as if he knew the correct diagnosis. With a very low voice, he muttered to himself that the problem could be an anaphylactic shock. At the same time, however, another physician had the stethoscope in her ears and was speaking with a third physician. Obviously, the chart holder's statement was not noticed. When the group then later found out the correct diagnosis and a physician ordered a discontinuation of penicillin, the chart holder told the others that he had already stopped it, but still did not mention the allergy stated in the chart. In group 7, the chart holder tried to get the attention of his two colleagues by pointing on the chart, but the others were busy with something else and did not react. This group discussed treating the tension pneumothorax. I think this is also very hypothesis generating findings that these people that they report here, which is that we appear to be reluctant to speak up in such situations, even if it's collegial situations, but this is ad hoc teams that are unfamiliar with each other. And there appears to be a social expectation or social pressure towards not interfering too much with what the others on my team do. And a second interesting finding they report, apart from the chart and how the chart was handled, is auscultation of the lung. The patient was auscultated by all groups, 1 to a maximum of 11 times per group, with a mean of around 5 times. The patient was more often auscultated in groups that actually missed the diagnosis. And in 10 out of 20 groups, at least one physician heard different sounds from both sides, being an indication of the tension pneumothorax, and that being the wrong diagnosis. Indeed, they did see more side differences being reported in groups that missed the diagnosis, but that's a tendency, that's not statistically significant. But in 9 out of the 10 groups where a side difference was reported by at least one physician, a second physician of the team also auscultated. So the pathological finding itself triggered sort of re-evaluation by a second physician at least. And out of these, all possible combinations were observed. So the first hearing the side difference and the second not hearing it, or at least indicating he didn't hear it, or the first hearing no difference, the second then hearing a difference, the first then listening again, also hearing a difference or confirming the difference. And bottom line, out of these 10 groups that had a side difference, all groups settled on the side difference. Not a single group where a side difference was mentioned did disagree on that finding ultimately. And so things to discuss or further investigate, in my opinion, is that I believe we generally overestimate the similarity of what we think with how others think. I think the second effect that is observable in this chart handling, how the chart was handled and how the information in the chart was communicated, is what psychologists call an illusory transactive memory system, which is our ability to pick the right person in a group to assign a task to. So we would all know who on our research group is the computer savvy, and we would assign the computer tasks to this person, even without having much knowledge about formal IT qualifications or anything like that. But on the downside, this ability to recognize ability in teammates or recognize competence in teammates also leads us to the assumption that me being on the team with you, I would expect that if you had information relevant to the case or important to the case, you would speak up. And by the fact that you don't speak up, I conclude that you don't have information relevant to the case. Then there is this observation of contagious illusions, such as the one that resulted in the confirmation bias in the groups that auscultated the lungs and heard different breathing sounds on both sides. And then a last thing I very briefly wanted to mention. Some of you might be familiar with the work of the Larson group from Chicago in the 80s and 90s. This group looked deeply into the amount of shared and unshared information on diagnostic healthcare teams, and what they found was that knowledge previously shared among the team members was more likely to be shared in the team discussion, and that knowledge that was uniquely held by single team members was less likely to be shared. And this research pretty much stops there. And I would argue that this finding, which has been sort of all we know about diagnostic teamwork, is sort of what we would statistically expect, because I mean, if the shared findings are the red balls and the sort of less shared findings are the yellow and black balls, and the unique piece of information held by only at the very bottom right.
Unmuted or not, but so I wasn't sure. There used to be a button that said raise your hand, but I don't see that. Anyway, I had a couple of comments. One is that I would be concerned that maybe the diagnosis of anaphylaxis was incorrect, and that the correct diagnosis might still be either a pneumothorax or septic shock. Thinking that most people who say or many people who say they're allergic to penicillin are not. And so just seeing that there's a penicillin allergy in the chart, I don't think really clinches the diagnosis. And maybe it really was a pneumothorax. It's difficult sometimes to determine whether lung sounds are different because they're really different, or because it's a noisy emergency room, or because you're hearing transmitted lung sounds from the good lung over to the bad side of the chest and so on. And certainly septic shock would still be a possibility if the patient wasn't actually allergic to penicillin. So I'm wondering how it was determined that that was the correct diagnosis. Was it a consensus among the investigators, or was this a real patient, and there was further confirming evidence that that really was the diagnosis? So that's one comment. The other comment is this is potentially valuable and potentially could be studied in real patients. Meaning in an emergency room with real patients. And I think it could be, you could get it by the IRB, you could just compare usual care with team care, both of which I think would be ethically acceptable And anyway, it's potentially doable and would add a lot of credibility to anything favorable you wanted to say about teamwork and diagnosis. So I'll stop there.
Thanks, John. I think I'll start with your second point first. I fully agree. I think this should be studied in real patients. One thing that is certainly difficult from sort of a research design point of view is the question, if we do this in real patients, how do we figure out the correct diagnosis? And how do we ultimately determine whether a certain behavior turned out to be leading to the correct diagnosis or not?
If I could just comment on
yeah,
that.
sure.
That actually is a huge problem, and it's the reason that we don't know the prevalence of symptom-specific diseases in primary care, because in order to get the correct diagnosis, you have to follow the patient forward in time, which is a lot of work. But that's how you get the correct diagnosis, or at least potentially. I mean, of course, in some cases, you'll never know. But in many cases, you can find out the correct diagnosis by finding out what happens to the patient. That requires a phone call to the patient. That requires that they answer their phone. You can't just rely on the medical record because maybe they went to a different hospital and so on. But it is potentially doable.
I agree. I agree. I think it's sort of two different questions we could address with the design this group used and the design you're suggesting. I think with your design, once we know what is beneficial and not so beneficial behavior among healthcare teams in the diagnostic process, we could sort of conduct your study in real patients to see how often do we observe either one, which I think is of huge relevance in terms of figuring out what we would expect to see and what we wouldn't like to see so much. These simulation studies have the advantage that we can just arbitrarily design a case that has a correct diagnosis, which sort of leads to your first statement, which I fully agree with. And I'm very glad you mentioned sepsis, because based on this study by Chun, we're currently conducting a study that looks at this ambitious case, and all these patients, all these diagnoses you mentioned, allergy to penicillin, sepsis based on pneumonia, and tension pneumothorax. I think it's the three we discussed, or you mentioned. All these three sort of appear with very similar findings, right? Decreased oxygen saturation, decreased blood pressure, increased heart rate, increased respiration rate, which is sort of the key findings. But they would have differentiating findings such as a rash or bronchial pulmonary obstruction in the allergy or in the anaphylactic, and then bilateral differences in auscultation in the tension pneumothorax, and maybe distended veins on the neck. And in the septic shock, you'd expect a fever at least, and so forth. So there should be I think the problem is to design a case that is ambiguous enough to pose a diagnostic challenge, but to still have a correct diagnosis. And we're currently we have just conducted or acquired the data on a study that sort of randomly gives one of these three cases, the penicillin, sepsis, or pneumothorax, to the groups, and we'll see if the groups that get the sort of the one where we think the correct diagnosis is the tension pneumothorax, if they end up to figure that out more often, because then all cases look more like tension pneumothorax or something. But that's a very valid point.
Good. I agree with everything you said, and hopefully someone else has a comment or question.
Hi, oh, I'm sorry, go ahead.
Please go ahead.
Oh, hi, this is Dan Mayer, and I had a question about the results that you got. You found that the groups that considered greater numbers of information were not more likely to find the correct diagnosis. And there we go, and could that be because they lack the knowledge, or is it because they're less secure with the diagnosis and felt that they needed more information, needed to get more information in order to make that? In other words, were they just failing in system one and therefore thinking that they had to go to system two more often to get additional information, or were they just stupider?
Very valid question, and I must say I wasn't involved with this study, sadly. So what the authors describe in their paper is that indeed that is a possibility, and they wouldn't know because they didn't test for knowledge. But they did look at what they termed experienced ICU physicians, and I've talked to the first author of the paper quite extensively, and with experience, they mean either board certified or close to certification. So with at least 3 or 4 years of experience on the ICU. And with that in mind, I would think that A, it's sort of unlikely, and B, I find the findings of this study even more astonishing and even more worrying.
So this is David. Thanks so much, Wolf, for a lovely presentation of this article. I have 2 questions. One is linked to the question that was just asked about sort of knowledge and right ideas, and it's sort of the question is more along the lines of whether you can teach this. In other words, do we believe that this is a property that can be externally applied to clinicians such that they will perform better? Or do we, in the sense of teaching teamwork or teaching talking out loud or teaching discussion, or do they have to learn something else? Do they have to have other kinds of mental skills or knowledge or whatever that are and this is the result, the downstream property that's correlated with the correctness of the diagnosis? And the second is a question about the extent to which this applies outside the kind of acute care context where the team is more physically distributed. How do you see this applying when, you know, the radiologist is one place and the neurology consultant is somewhere else, and the process is unfolding over some longer period of time, not minutes, but, you know, hours, days, weeks, etc.?
I'll answer the second question first because I think it partially answers the first. So you're fully right. This is acute care with sort of immediate action pressure. This is ad hoc teams, unfamiliar teams that have never worked together before. This is very different from what you have, let's say, on a ward round where you have a team, or in these distributed healthcare teams you just mentioned, or in teams where sort of the process unfolds over a much longer time period. And I think all this is to say that we know very little about these healthcare teams and these diagnostic teams. I think acute care is sort of a thankful area of research into these teams, because you can sort of observe the processes under the looking glass in a very limited time frame. But I have no idea if we can observe these processes in distributed healthcare teams or in acquainted teams. And what we know from airline pilots is that, I forgot the name of the author, but there is a beautiful study where they had a team of sort of rested pilots that hasn't met before. They put them into a simulator and had them work through an emergency scenario with their plane, and compared that to a team that just came off a 5-day rotation, was tired but acquainted, and the acquainted team performed way better than the ad hoc team, which I think is sort of a surprising finding, given that airlines generally tend to split teams apart rather sooner than later. So briefly put, I think we know very little, and we plenty more research there. Can we teach this? I wouldn't know what to teach at the moment, because I mean, if you look at these crew or crisis resource management principles, they say things like speak up or practice closed loop communication. And maybe if the participants of this study would have spoken up, they would have performed better. But this Franziska Chan group, they also conducted a study with a CPR scenario, so a resuscitation scenario. And what they can clearly demonstrate there is that in high acuity action tasks, where it's not so much a consideration and thought task, but more an action-focused task, speaking up by team members is actually lowering team performance, which is the opposite of what we're currently teaching in these crew and crisis resource management principles. But I think these crew and crisis resource management principles, they give us a hint towards what could be the behaviors we should be investigating. I think they shouldn't be taken literally, because I mean they say things like be a good team member, and that's very hard to teach. I wouldn't know what that is, a good team member, and I would assume or hypothesize that the definition of good depends on the task at hand. Very lengthy answer. Sorry.
Thanks. That makes a lot of sense. I think Kelly Gleason had a comment or a question.
Yes, and I think
well, I did. It was just very, very loud in my house at the time. I like how you pointed out that you had it in like the ambiguous slide that the information that the nurse has, it adds into your idea, but it's again it can at sometimes fall into the difficulties figuring out exactly what's going on. I am a nurse, that's why I was interested in your comments towards that.
Sorry, can you say that again?
It was really more just a thought than a question.
Okay.
Yes.
Dr. Hautz, I had one question that, or if anybody else in the groups had that, but I had a hard time distinguishing the difference between what they refer to as explicit reasoning and talking to the group. And to me, it seemed like they more or less represented the same phenomenon, or at the very least that talking to the room was a subset of explicit reasoning. And if there's a reasoning why they specifically, chose talking to the room as a category they focused on.
Yeah, so indeed, the coding scheme was devised before they acquired the data, just simply based on theory and the literature. And they said, let's look at two things. Let's look at communication and behavior. And with regard to explicit reasoning, they said this is a communication phenomenon. And we will code everything as an explicit reasoning when you use causal conjunctions such as because or if then or anything like that. Whereas this talking to the room, they said we'll classify everything as talking to the room when we observe in behavior where you are speaking, but you're not addressing anybody by means of looking at someone or by means of approaching someone. So basically talking to yourself or talking to the room. And what people typically did, what they observed when they coded this talking to the room, is they raised their voice, which I think is a familiar behavior to emergency physicians and nurses. If you want to make the whole trauma bay aware of something, you'd probably raise your voice and not look at someone in particular. But I fully agree, and they, I think, also do with your comment. What's the difference between these two? And I think in the end it's hard to say, which is why they sort of created this combined index of reasoning and talking to the room, which sort of, I fully agree. I think it captures the same thing.
Great, thank you. We have a comment from Dan Meyer. I don't know if you're still on or if he had to leave. Would you like to ask your question or comment?
Sure. This is Dan. Hi. I'm sorry. This is my first time on GoToMeeting, so I'm not sure which method to use. But we teach closed loop communication, and Wolf, you kind of triggered this when you said it about work. But we teach it usually in relation to management of the patient and not in terms of diagnosis. And I'm not quite sure how we would do this, how we would teach this in diagnosis, because what usually happens is the nurse gets some information, the physician gets some information, and they're sort of supposed to put it together, but the nurse is never queried by the physician about all the information they got, and vice versa. It's usually been up to the physician to obtain that information. In other words, whatever the nurses wrote in their note is the responsibility of the physician to have read and found out, and not the other way around, at least not usually in my setting in the emergency department. And I'm wondering, is there some way that we can better teach this, or even create a system or some process by which this could happen? Maybe this would be an interesting brainstorming session for future meetings.
Yeah, I fully agree. I observe the same phenomenon. Patients in our emergency room, they tell their story to the triage nurse. They tell their story again to the nurse that takes them into the bay. They tell their story again to the resident in charge, and they might tell it a fourth time to the supervising consultant physician. And when they get to the supervisor, they are really annoyed. And they hardly tell the same story 4 times. So they'll refer to other information, and I fully agree. We should have a way to pool this information.
Good, thanks. I'd be interested to hear other people's comments on that too.
This is John Ely again. One thing I've noticed with the introduction of the electronic medical record is that we used to have a narrative from the nurse in the chart, and now all we get is numbers. And it's actually there's a place for putting notes, but it's kind of rare to see any actual sentences or prose in the medical record from the nurse. You get hundreds of blood pressures and temperatures and ins and outs, but you don't get any open-ended prose. And so I think that's changed. When we had written records, we often had a brief sentence or two in the chart about what the nurse observed during their shift. The other comment I was going to make, which is completely unrelated, is that teamwork might be more difficult in the United States, where you can't really bill for it. At least you can't bill for informal teamwork. You can bill if there's a formal consult, but if I were to go and discuss a patient with another physician, whether they're the same specialty or a different specialty, I'm taking their time away from a billable activity, and so there's a financial problem with teamwork.
I fully agree that teamwork is certainly heavily affected by contextual factors such as nationality or culture. One problem I have with this study I was briefly alluding to that we're currently conducting is one category where coding is instruction. And we want to know how often do lead physicians or nurses give instructions to others on the team. And we only find questions, which is a very cultural thing. In Berlin, you'd find a lot of instructions because Germans, they do instruct, or we do instruct. Whereas in Switzerland, a Swiss instruction is, can you please give adrenaline? That's sort of an instruction, but it's it's technically a question. So yes, I fully agree. It factors such as billing but also factors such as expectations, social expectations, certainly heavily shape how we interact in these healthcare teams.
And I think one solution that the authors sort of refer to in this article is if it makes sense to sort of standardize the diagnosis process and protocolize and making it so that everyone in the team is expected to speak up. And if that sort of with the checklist and the way that it's shown to improve outcomes in management of conditions, if that would have the same outcome for getting to diagnoses.
Yeah, I mean, I don't know about United States, but here we don't have any formal leadership education. So resident physicians that sort of make the transition to senior resident or something and that are expected to lead an acute healthcare team, they have never learned the value of thanking subordinates for speaking up, and they're either smart and attentive and they figure it out at some point, or they're not. But there is no formal education that teaches people when you coordinate, to not say lead, when you coordinate a healthcare team, what we expect of you is to encourage speaking up of everybody on the team, because that increases the likelihood all information is shared. And to involve people in the diagnostic process, to have people agree on the next steps, and so forth, which involves a lot of explicit reasoning and a lot of talking to the room. But we never actually teach people that, at least not in Europe and Switzerland, or in Germany and Switzerland.
And it's interesting in the case that you presented with your data, it showed that working in groups was helpful, but in that case, both of the people were med students and on the same level. Be curious to see the groups that didn't do well in this study, if there was more of a dynamic in age or experience, so one team member felt less likely to speak up.
Yeah, we haven't found anything in the transcripts, and we haven't found anything in sort of ability as measured by assessment performance. We've even asked people how confident or how comfortable were you with working with your fellow teammate. And in all these data, we didn't find anything. But then, on the other hand, we took very great care to create pairs of equally ranking medical students, so from the same level of experience, same age, and so forth, to not create differences between the individuals in the pairs condition. So that we could be sure the difference is truly to the condition and not to general ability or anything like that. But yeah, these data don't help to answer the point you raised.
Great. So I think we're at the end of our hour. Thank you very much, Dr. Hautz, and for everyone for joining us. If you have any recommendations for future journal club sessions, we'd love to hear from you. So we will go ahead and close the session.
Sure. Thanks for having me.
Thank you so much.
Thanks, Wolf. Bye-bye.
Bye-bye.